Okay, patella fractures, super briefly, because we only got like 10 minutes. So tension band concept, you put the, you convert a tension force into a compressive force. Patella's got all kinds of different facets, but basically it has two articular surfaces, medial and lateral. There's many different patterns. It's just a descriptive pattern, or sorry, a descriptive classification for these fractures. And then this is an important point, how to image your patella intraoperatively. So you need to be able to see both of those medial and lateral facet surfaces. And so you're angling your beam intraoperatively to make sure that you have a reasonable reduction. I think your goals of treatment here need to be clear. And this is another fracture where we're doing an awful job on, and I'll show you some literature on that. But our goal with all of this is, number one, to restore the extensor mechanism. That's the most important thing. We're not doing a great job at that. And you can test this out yourself. If you do not get full extension, even if you're lacking 5 degrees, your quads are always activated and can never relax. You can also never gain full contraction of your quad. So if you stand up and lock your knees, you can generate a ton of force into your quad. Whereas if you stand up and bend your knee 10 degrees, you can't flex your quad as strong as you were when it was locked. Secondarily, looking at getting congruity back and getting stable fixation to start early range of motion. Non-op is a thing. There's actually a camp of people who are trying to research whether non-opping all of these, even people with non-intact extensor mechanism, should be the move. So stay tuned. There are a million different things that you can do to try and fix your bony pieces back together. And whenever there's a bunch of ways to do something, it's because none of them are good. The classic is tension band wiring. And basically from there, you start to get to more and more complex things based on how displaced and how fragmented your bony ends are. So this is just a little bit of evidence to tell you how bad we are at this. This bottom paper is probably the best one to look at. So it's functional outcomes after operatively treated patella fractures by Saji. And he included all techniques of OIF, 240 patients, and it was a mean of like 6 years follow-up, so pretty good. Half had their hardware removed. People who had it retained mostly reported pain. They had a pretty big subset of people with an extensor leg and a big strength deficit when compared to the other side. There's been no studies that have looked at direct comparisons between two treatment options. And I think that's because every patella is like a little snowflake and they have their own special things to them. So it's very difficult to standardize these fractures. But if you want to be super famous, like Claude Saji, I recommend doing a study like that. And then the latest kind of addition to the patella fracture world are mesh plates. These are, well, I'll show a picture of them, but it's plates that are going on the top to try and catch all of your fragments. Proponents for it say that you can get more fragment-specific fixation. It's pretty low prominence, so they report less hardware issues. And like this paper of retrospective review of 12 patients, 0 had any problems. They're all living perfectly happy, obviously. But I think there's more to the story, and there's very little research into mesh plates right now. So just a couple of pearls for how to put these things together. I realize we got like 5 minutes, but when you're doing your dissection, be really sparing. So that retinaculum and all the soft tissue attachments to your bone, that's what's going to help heal this, not whatever you do. So be really cognizant of not dissecting everything off of your bone fragments, because that's really what's going to help them. When you get to this view, when you've got the 2 fracture fragments opened up and you can see the joint, that's when you need to wash out your knee joint and get any giblets that fell into the joint. This is also the time where you start to piece together the joint. So we've got the best view at this point when it's booked open. So my advice, when you're at that point, piece together the distal pole, piece together the proximal pole, because right there you can directly see how good your articular reduction is, piece it together and wire it. And then you're going to close those two fragments together, and you've now lost your direct visualization. So the way that you can gauge your reduction at that point is you stick a finger underneath. So you make an arthrotomy, put your finger underneath, and clamp those two bone fragments on top of your finger. That makes the reduction really easy because you can manipulate the fracture line with your finger, but it also allows you to feel that reduction, because otherwise you're just taking a shot in the dark, and the the subcutaneous surface of the patella can't be trusted. It's really crappy bone. It's going to fragment, and it's not going to give you a good cortical read that is going to indicate a good articular reduction. And then don't be scared. You got to test your fixation intraoperatively, because you're going to have to trust this enough to get there and be moving. So here's a case. We got about 4 minutes. Anybody want to tell me what they're going to do with this? Disaster. Eric, you were in there with me on this one.
Yeah, that's right. We're gonna plan to not use a mesh plate, and then we're gonna use a mesh plate.
Yeah. Oh yeah, man. Oh, that was awful. Well, so this was really difficult.
Yeah.
Eric and I, we had a plan, and the plan fell apart. But we were trying to do what I was saying: piece together the distal pull, piece together the proximal pull, put it all together, and make it as simple as possible. I think that should be your goal with any fracture, is trying to break it down into the simplest form. If you can make this into a transverse fracture and then fix it with a tension band, that would be glorious. That was never in the cards for this fella. Yeah.
The thing that that was interesting about this case, I think, that sort of highlights the patella being a weird bone, is that it almost delaminated. And that's what forced our hand to use something that had some A to P fixation.
Yeah.
So
you can see it here. See that little bony fragment that's hardly even showing up now that I covered it with a line? That's like an example of where this thing was delaminating. So that subcutaneous surface of the patella was just falling apart. And then so our articular reduction looks reasonable on this, but when we flex it up, you can see this gap would open a little bit. So that was our impetus to introduce this cerclage wire. Overall, it looks pretty fancy, but I'd say hardware removal is in the cards for this person, and hopefully I'm gone by the time this hardware needs to come out. It's going to be a doozy. Maybe it'll be Dr. McDonald's job.
He's got insurance. He's not following up with the general.
Oh. Perfect.
I heard he likes Toronto, actually. Maybe.
Oh yeah, I'll send him up there. We got a couple screwdrivers, I think. This is the second case, just to highlight a little bit of a different technique. This was like a week later. Eric was gone, so we decided to do some real surgery on this one. And also smashed. And we used a slightly different technique where we're looking at kind of more specific fragment fixation. So this was with Dr. Toogood. We used the same idea, try and put in as many K-wires as we possibly could. And the idea there was just trying to make more simple fracture lines so that we would have better fragments to work with, so that we can create that tension band between those two fragments. So wire them all together. We basically reduced it to two big fragments, one at the top, one at the bottom. And then this big plate here is a 2-0 plate that we essentially used as a tension band. So you curve it, and I wish I had a lateral here, but you curve it, you put it towards the joint surface, and you screw it in with a long screw, but then you gradually walk your screws up to the other side so that it's kind of curving that plate as you walk up. And then you do the same on the far side. You create this tension band plate. Both have a similar concept, and honestly, there's no evidence to say one is better than the other. The best I would say is just be really sparing with your dissection. get these people moving if you can, because they're going to get stiff, and watch them for infection and wound issues, because they happen pretty frequently. There's a little bit of evidence here. Oh yeah, no, I talked about that. Okay, you guys have any questions in -1 minute to talk about tibial patella fractures or patella fractures? Nada, all clear? Perfect. Okay, well, I'd be like, I got a bunch of cases, and another time we can do cases if you want and just go through them. But yeah, enjoy humorous.